Here we are just continuing on. This is a bit of repetition from the previous slide, and I just really want to point out on this slide what the actual structures look like. So we have the terminal bronchioles, and then we get to the respiratory bronchioles. And the difference between the respiratory bronchiole and the terminal bronchiole, other than that diameter, is the fact that the terminal bronchioles are often studded with one or two alveoli. Okay, and then we get into the alveolar sacs, and then finally the alveoli themselves. Okay, so now, because this is the site of gas exchange, we have about 300 million alveoli per lung. And if we stretch that out, that will give us a combined surface area of about the size of a tennis court. So a lot of surface area for exchange. We also see a rich, dense network of capillaries that kind of overlays the alveoli and the alveolar sacs, and that is also contributing to diffusion, that rich, dense network of capillaries, as well as the fact that we have so many alveoli, right? Lots of branching, lots of alveolar sacs, lots of alveoli, and this just enhances the amount of diffusion that we can get. We also see pores in between these alveoli. Excuse me. So they're not separate and independent. They're actually communicating to each other via these tiny openings. And that's going to become really important as we speak about the pressures and the pressure gradients. So having the alveoli able to communicate through these pores allows us to equalize the pressure in an alveolar sac, right? So you don't have different pressures in different alveoli. You can equalize the pressure throughout that entire alveolar sac, and that will contribute to the presence of the pressure gradients that we'll speak about probably next time we meet. I'll speak about these slides, these cells, a few slides down. So this will be repeated. And here we just want to highlight the magnitude of or the number rather, of capillaries that we see, this rich network. So in white, we can see the airway branches, and in red, we can see the capillary branches. So you can see how extensive and how dense this network of capillaries is. And that again is facilitating lots of diffusion of those gases, carbon dioxide and oxygen. On the right, we can see a higher magnification of this. We can see, again, alveoli studded in between this rich network of capillaries, which help with that diffusion. Okay, so these are the cells that were on that previous slide that we'll speak about here, where they're better illustrated. So type 1 alveolar cells are the actual lining epithelium of an alveoli. This is a thin layer of cells that form the outer surface of the alveoli. They are basically fused with the capillary membrane. We're going to see that in a minute or so. Type 2 alveolar cells have another important function. They are less abundant in terms of their presence in the alveoli, but they secrete surfactant. So surfactant is really important here because it helps to maintain the patency of the alveoli. So whereas we saw cartilage in the upper aspect of the airway, whereas we saw smooth muscle also in the upper aspect of the airway. Here, because we've removed all of those obstructions to diffusion, we still need something to help keep this open, and that's the role of surfactant. So surfactant is one of those amphipathic biomolecules, those lipid molecules we spoke about, and it's going to help decrease the surface tension and maintain the patency of the alveoli. The alveolar macrophages are the third kind of cellular structures here. These are one of our leukocytes that we spoke about that actually extravasate from the blood. Anyone remember the precursor cell to macrophages? Monocytes, yeah. So monocytes, they're going to leave the blood, and when they move out into the tissues, they then differentiate into macrophages. And so that's the function of this cell here. Is going to be a part of the immune system, engulfing debris, pathogens, anything that kind of made its way down to this distal part of the airway. And once again, because we don't have cilia and we don't have goblet cells here in the distal part of the respiratory tree, we need something here to kind of take that function. And that's what the alveolar macrophages are doing, kind of engulfing any debris or pathogens. Okay. And we can also see the pores that I was mentioning earlier that help to communicate one alveoli to the next. All right, let's speak about the respiratory membrane. Right, so make sure you're kind of keeping this terminology separate. This may get a little bit confusing here. So we talked about the upper airway and the respiratory tract. And then of the respiratory tract, there were two components, the conducting zone and the respiratory zone. And then of the respiratory zone, there's the respiratory membrane, okay? So the respiratory membrane is created by the epithelial layer of the alveoli, those type 1 alveolar cells, and the endothelial layer of the capillaries from the blood vessels in this region. And basically, we typically have the epithelial layer and the underlying basement membrane of each of those cells. But in this location, both of those basement membranes have fused. And because we have the fusion of those two basement membranes, we simply have a smaller barrier for diffusion between the alveoli and the epithelial cell. Okay, so that's a really important adaptation for diffusion here among the alveoli, that fused basement membrane to kind of limit the number of stuff that those gases have to get through. Okay, and this trio of structures here, the alveolar type 1 cell, the basement membrane, and the endothelial cell is what forms that very thin respiratory membrane, okay? All right, so here's a nice, another electron micrograph showing the alveoli, which are nothing but these open sacs. And then we can see one of the terminal bronchioles here, which are feeding that alveoli. Okay, so because we just mentioned that the alveoli are simply these sacs of air, a very thin wall, we have to have a measure of protecting the alveoli. The lungs are very sensitive to injury, sensitive to damage, because we don't have cartilage out in the distal part of the respiratory tree. We don't have smooth muscle even, and so there's a lot of susceptibility to injury. And this is where we have the chest wall that's kind of protecting the lungs here. We've got the rib cage, which is formed by our ribs that are corresponding to the sternum via that costal cartilage, and then eventually to the thoracic vertebrae at the back. And that creates this nice kind of cage-like structure that protects the ribs. We also have the muscles, right? All of these we've already spoken about in labs, the external intercostals, the internal intercostals, and most importantly, the diaphragm, all helping to protect the lungs and to form this nice airtight seal. We also want to talk about the pleura. So the pleura is this double-walled membrane or lining that wraps around both of the lungs, right? So it's separate on each side, and it's created by those two layers that we talked about, that visceral layer, which is really intimately connected to the lung itself, and the parietal layer, which is intimately connected with the chest wall, right? If you remember that structure from lab. And so in between those two walls, that visceral and that parietal, we have this intrapleural space. So it's a very tiny space, usually occupied by a very small amount of fluid. And we'll talk about why there should never be air in this space. This is kind of a negative pressure space, and there should only be this small amount of fluid, about 15 milliliters of fluid, okay? So some of these structures, we'll continue to look at the diaphragm and the pleura because they're really important in the mechanics of how we breathe, how we get air to go into the lungs, and how we get air to wash out of the lungs as well. All right, so on this final slide here, we can see those structures. The rib cage, the intercostal muscles, which are kind of studding those ribs. We can see the trachea, the primary divisions of the bronchus, the lungs here. I want to point out the diaphragm. So does anyone know what state of ventilation we're in when the diaphragm is nice and rounded like that? Sorry? I think I'm hearing it. Exhalation, yes. So this is expiration. So when the diaphragm is nice and rounded or dome-shaped, we're in expiration because we're increasing the abdominal cavity, and we're decreasing the thoracic cavity. And this is going to help create the pressure gradients that we'll go on to speak about, right? When we're inspiring or bringing air in, the diaphragm drops down to about here, becomes nice and flattened out, and that kind of reverses those pressures, again, which we'll go on to speak about. I also want to point out on this slide the intrapleural space. This is a really important zone It's supposed to be only a small amount of fluid here, and it's in between the lungs, which are creating a force onto that wall, and the rib cage, which is creating an opposing force onto that pleural sac. And we'll go on to speak about those components as they apply to breathing. Okay.